I guess, and heartbreak over how broken and inequitable our system can be. So really appreciated some of the very direct calls for vision and leadership in terms of making those plans, and look forward to seeing that and being part of that. And also like reminded, I mean, I'm constantly reminded in my job, that's why I work for a union, of like the role of a living wage and steady employment and employment with benefits and all that plays. So look forward to us addressing that. On a more technical level, I also generally operate under the assumption that there is enough money being dedicated in the healthcare system. We spend a lot of resources on the overall healthcare system. So when I think about struggling parts of it, my mind goes right to like, where is the waste, or where the money's in the overall system. So where is it, and where does it need to be? And so with the pandemic, have been thinking a lot about alternative payment models and capitated models and our struggling primary healthcare providers. And so hearing Jeremy's presentation earlier in the meeting was not a surprise. And then hearing both CCOs who spoke, All Care and HealthShare, both talked about alternative payment models, and All Care specifically said that they're continuing their capitated models to providers. And I get that FQHCs are outside of APMs and really operating solely in fee-for-service. But I guess I'm curious if in the survey of providers, were there crosstabs or something, or there's a set of providers who are struggling. Mm-hmm. How does that struggle differ geographically because of how different CCOs maybe are operating, or how in-depth their capitated model has gone? Or are providers that segmented, that we have, say, Medicaid providers in Southern Oregon under capitated models that are doing okay, and those on mainly commercial payers are not? Mm-hmm. I'm interested in pulling back that onion and seeing those layers and distinguishing between who's succeeding and who's not, and how do we draw out those stories to both like highlight successes and think about like how do we scale those successes up, and highlight them so that people who have been traditionally hesitant to move towards capitated models can hear from their peer on the success of it.
Great, thank you. Rosenda.
Okay, can you hear me?
Yes, we can.
Yeah. Oh, okay. Well, I think that my reflections, I think I was the mostly struck by the Oregon Latino Health Coalition, and how, I can't remember which speaker it was, but she brought up about that there was a need for an OHA strategy, and said that the Latinx and the OHA are partners, and which is true, but I would also like to mention that there are other partners too, as long as we're looking at the equity side of things, and don't want to leave out the indigenous people and the Black people and the Asians and whomever. And I know that this was the Latino Health Coalition's presentation, and that was their request, but I just wanted to make sure that the OHPB and OHA, you know, when we do develop and come forth and adopt a strategy, that we do look at what they said, you know, about the partnerships, because I think that as long as well, I guess what I heard from most of these presentations was that they were community, they were from the local community. And to me, that's very important that that is brought into the picture fully, that each community, each area, each county, all have kind of a different makeup of the population and just everything about them. It's almost like, I think I heard at the beginning, you know, like we aren't just one, it's 36 counties in the state.
Mhm.
And so I think that that's a very important area that I think that we need to really look at this strategy that was brought up during that first presentation.
Mhm.
And then I don't know what stood out or surprised me the most, I think, is that I know that these were fairly broad and general presentations from each of these presentations, but I think it was James Schroeder on the health chair of Oregon, where I only heard mention of the elderly and how they possibly might need assistance with the technology, telehealth, and not being able to understand, and the education that's needed. And I think that, you know, we talk about the disparities and the equities, and, you know, well, like I said before, this was a broad presentation, but I really had hoped that I would hear kind of maybe a little bit more of specificity on what these groups did, or if there was any particular area where mainly the aging, elderly, seniors, and how what role that they held and had in within these organizations, because that's a really important
Mhm.
part of, I think, what we need to be addressing is that I know we talk about prevention, and, you know, and I was looking at those 13 the metric scoring, and I know that they're all, you know, pretty to me, it just seemed like they were mainly, you know, the immunizations, well child, and teeth care and all that. It to me, it just seemed like they were kind of for the younger set, you know, which is fine. You know, I have no problem there. But sometimes I think that maybe the senior group might not speak up loud enough, and maybe we can assist there. And so I wanted to bring that up later too, you know, when we talked about some of our priorities for the coming year. So those are just a couple of the thoughts that I have for today. Thank you.
Thank you, Rosenda. Yeah, I think it's really important in terms of how COVID is impacting the elderly in terms of increased isolation so they can stay protected, but also, you know, the impact of COVID on, you know, sort of the risk of the elderly in terms of the impact of them getting seriously ill and dying. So thank you for raising that. Zeke, what are your thoughts?
Thanks, Chair Mangsburg. A few thoughts. One, I just wanted to acknowledge I really appreciated the intro that Jeremy gave, the input from Olivia and Serena, and then the 3 representatives from the CCOs. It felt like it was nice to see multiple levels of the system, which I think both pointed out where there are systemic gaps and issues, but also it was important, I think, to hear voices from different perspectives. And for me personally, it gave me a sense of actually the more that is being done specifically to try to address the issues around the health inequities, specifically with COVID. So that was really valuable to see, and where I think, you know, people have called out this need around more of a systemic strategy to coordinate and to align those efforts. I was struck by what I think has always been a tension in the system of where accountability should lie, and then what kind of flexibility is associated with that accountability. So should we be asking OHA to really be the accountable party and then to dictate and define what everybody should be doing all the way down to the provider level? Or do CCOs have, what level of responsibility do CCOs have in that? And how does the funding align with that or not align with that? I heard this, what I think was a tension between reduced utilization, therefore less resources available, and then an interest in trying to invest more in community-based solutions, but that the resource base that CCOs have is not typically as available for that. That may or may not be true, but I kind of think I heard that. And so I think trying to get clear about where there are those systemic barriers around the billing system versus more of a value-based system feels really important to understand. And then figuring out, I think part of what we were trying to accomplish with CCO 2.0 was to increase accountability when we're not seeing results in a CCO region and in a community that align with what we're trying to do in the system, but actually a decreased level of accountability, or wrong word to say, but a decreased level of authority from OHA in places where things are happening as they seem like they should be happening. I was really impressed by the presentations, specifically from All Care and Pacific Source in the Gorge. I liked the way that in All Care, I could see a relationship between how they're using their resources, the kinds of impacts they're trying to get in the community, and then some results that are connected to that, as well as tying it to a longer term sustainable plan. And I would want to see that across other CCOs as they're in a position to report back to us. And I think, Director Allen referred to a report that's going to come out that has some other implications from around authority and where it lies. But I just think this question of like how we effectively support localized responses to specific communities, culturally specific communities in particular, but not exclusively, but do that in a way where we know that the results are actually aligned with what we're trying to accomplish. Because I think that we're pretty clear together, not just the OHPB, not just the Oregon Health Authority, about what kinds of changes we want to see. And clearly COVID has given us an opportunity to better understand what our systems look like today and where we might make some of those changes. And just one last piece that I appreciated in what you said, Jeremy, and then what I think was echoed throughout the others was the need to not just move back to what normal was before, but the opportunity to really lean into where we've seen change that's occurred that's been productive, as well as the opportunity to surface where we've got real gaps that are not OHA's fault or responsibility alone, that are not the fault or responsibility of our CCOs alone, but actually are places where we need to be more aligned in how we're working to address those issues. So really appreciate today. And I also recognize it takes a lot of effort to put together this kind of presentation. I know that that's not something that is like a monthly opportunity for us, but just to acknowledge the work that goes into making this happen. But felt like today I got a better sense of the system than I have gotten in a long time. So thank you.
Thank you, Zeke. I appreciate your comment of accountability versus flexibility to innovate in an unanticipated challenge. Obviously, we saw some real innovation today to respond, and obviously we need more. John.
Can you hear me?
Yeah. Mm-hmm.
Yeah. Well, yeah, I look at this, of course, in light of my own situation. I'll be 70 in September, and it's truly frightening to look at the statistics for 70-year-olds and see that my wife and I have a 1 in 3 chance of being hospitalized if we get coronavirus and a 1 in 12 chance of dying. We're both healthy. Our most serious problem is coronavirus. And as I listened to the Latinx presentation, I think my first priority is to do everything I can to help them figure out how to get this solved. The healthiest thing for me is for the Latinx population of this state to get a lot healthier. I mean, I'm impressed that we heard from 3 CCOs, but I have a feeling that they're the best performers. They're doing the most to try and figure out this. And I have questions about, you know, one of the issues has always been you see one CCO, you see one. And where are all the other CCOs when it comes to this? You know, I asked the question I asked finally because I think it's a all hands on deck moment. I've paid insurance premiums to commercial health insurers and now to Medicare, a Medicare Advantage plan my entire life. Where are they? You know, they're nonprofits. They have an obligation to the community. Where are they? Now, I want to say that I think Providence and MOTA and Pacific Source are where they should be, or at least a lot closer, because I think they're all doing something. But I don't know about the others. And, you know, I hope one thing the Latinx folks start to do is I'm a bit surprised that I didn't hear that workers' comp is doing something. I mean, look at all the workplaces that have had outbreaks. In my mind, workers' comp should be a player here and realize what a difference it could make, because workers' comp is you're going to get paid while you're off work. You're going to get your hospitalization paid for. And if the worst happens and you're disabled or died, we're going to step up and take care of your family. Where's workers' comp? Those are my comments.
David, you're on mute, but I think you.
Vice Chair Ron, Oscar.
Yeah, thank you. I echo a lot of the comments that have already been stated. I would say, you know, there's a lot of things that I heard today that were very concerning. And yet I do feel like there is a sense of optimism and hope that we can do better and that we shouldn't go back to what things used to be like. We cannot go back to that places before the pandemic. I really want to make sure, to me, it's going to be very important that we actually document, you know, these lessons learned and things that we do not want to go back to. You know, I suppose that the timing in a way is maybe the right time in terms of these plans that are going to be due this fall, and this kind of focus on health equity, this focus on Black, Indigenous, and people of color communities. So I'm optimistic. I'm excited to continue this conversation as we move forward.
Thank you. And I think Brenda's not here. Did I didn't miss anyone, did I? No, board members? All right. I think, well, thank you for OHA, Jeremy and Trilby and Steph and everybody and Pat for putting this together. I think it's a great opportunity for us to have a discussion. I just was really impressed, Jeremy, with your presentation in terms of the financial demands that are being placed on the system, on the state. You know, the biggest buckets of budget, not only OHA, but DHS, which is going to have a lot to do to respond to COVID, the downstream effects of COVID, but also the education system. I've been part of the governor's task force to how to bring back education, and also in some discussions with Portland Public Schools. And, you know, the educational system, to deliver safe education to K through 12 is going to cost a whole lot more in a post-COVID environment or in a COVID environment than it will. So, you know, all these systems, all these big pieces of the budget, state budget, have to do more and we'll have less. And we're really in a bind. You know, I reflect in terms of our work together, I reflect on CCO 2.0 in these presentations. We knew equity plan was important. We knew community health workers was going to be important. We knew social determinants of health were going to be important. We knew that behavioral health integration were important. They were important before COVID. It seems like they're so much more important now with COVID. You know, in terms of equity, we hear that loud and clear. That's never been more important. And the reliance on community health workers and social determinants of health in terms of making people have food and just responding to the mental, emotional health challenges of COVID. And we talked about telemedicine. So these things that we have in place, you know, their importance, I think, is really highlighted in this challenge. And I think the question I have for future discussions is, you know, when we've had these major financial shifts from private insurance to public insurance, from fee for service to capitated, some of the points John's raised previously, how does this impact flexibility of CCOs to respond to these central areas that are so important in COVID? And, you know, the programs that are capitated, you know, and there's less services being rendered or less people coming to care, does that create more flexibility to fill some of these gaps? Or does the drain on the fee-for-service system really limit flexibility? So I think, you know, understanding the financial shifts and how we respond to these core elements in a really tight fiscal environment is going to be a really tough challenge for us all. I think we still have a few minutes for discussion. Debbie or Steph, should we end at 11:30?
So we still have a presentation from Stacy that we could fit in here. So I don't want to rush you at all. You're welcome to continue, but we'll have about 20 minutes for Stacy, 20 to 25. And then we have 3 people who have submitted interest in providing public testimony.
Okay.
So backing up from there, I think we
have
let's
make it 5 more minutes to see what reflections the board has.
Chair Bainsberg, I have one thought.
Yes, please.
I just in listening to the reflections and responses from the board, well, it's 2 thoughts. One's a quick one. I appreciate these times when we have the opportunity to engage. So thank you for making that time today. But the broader reflection is, you know, I'm finding myself thinking about the fact that there is no one institution that is responsible for the inequitable results that our health system gets. It is not really a health system. It is a system made up of all kinds of different parts. We've talked about that, but I would love it as folks move forward if there is an attempt to create a space where people can have the courage to really identify what's not working and not have to worry about whether that's someone else's problem or my problem in the institution that I own, but rather just be able to surface where those real challenges are coming up in the way that we do business, in the ways that we have done business. So I just think that the more that there is an open dialogue, and I understand the challenges with that in the forum that we have, but the more that there's an open dialogue, the more I think that we'll collectively be in a position to think about how we address some of those challenges along the way. So that's happened a number of times over the 7 years I've been on the board. And the more it can happen, I think the more there's opportunity for really addressing and shifting. And I think Oregon is in as good a position as any place to be able to really tackle some of these issues in a meaningful way. So thank you.
Thanks, Steve. Other thoughts? Based on your collective board member comments. Jeremy, Pat, do you have reflections after this discussion you'd like to share?
Just quickly, this has been it's been a great discussion, and it's been good input, and it's not been new input that we haven't been hearing. I've also been frustrated around some of our challenges in some of the response, and I guess I do need to kind of put on the record out there for you all the fact that we've known from the very beginning, actually clear back in early February, early March for sure, that a key to the response was going to be engaging communities with trusted partners in languages spoken by the people that need to be served and in ways that are culturally appropriate, and particularly in an environment like this around contact tracing and quarantine and isolation and those kinds of things, that the relative value of a government worker from the county or the state showing up was really different than a community worker from an organization that's got a relationship in the community. And I'm incredibly frustrated that it's taken us actually 3 months to finally get the resources that we asked for at the very beginning of this. Half the pandemic, we've been waiting on significant resources to be able to do that work. I'm delighted that we're finally now getting them, that we finally got contracts in place with CBOs, and that hopefully next week we'll get a significant amount of resource that will help actually fund things like providing childcare and food security and housing and some degree of income replacement and all those kinds of things that we've known from the very beginning are critical to one of the biggest drivers of our inability to reduce the rate of infection, especially in the Latinx community, which is effective isolation and quarantine, especially for people who don't have who have mild or no symptoms and have an imperative that they got to be able to go to work and feed their family and provide their housing and all those kinds of things. So I share people's frustration that we are where we are, and I'm very hopeful that we can now begin to make some serious progress, given that we've got finally the resources that I think we need to be able to do that work.
Great. Thank you, Pat. All right. Well, thank you. As always, I always learn the most from each of you. So thank you for sharing your thoughts and this opportunity to have this reflection. Let's move on to Stacy Schubert to talk about incentive quality metrics. This is a conversation we had during our last meeting, but we ran out of time. I think there was interest in having some more discussion and reflection on this. And I think Stacy's going to just summarize where we were at that last discussion so we can have some time for discussion.
Yes, thank you, Chair Bangsberg. Okay, Michelle, thank you. Sorry, I need to move things around a little bit on my screen now. So, good morning. I really appreciate the opportunity to speak with you today about the CCO Quality Incentive Program. I feel like this is a pretty hard act to follow, all of what we have just heard and the really important things that we've just talked about. So it's a little diversion, but I think that the Quality Incentive Program is a very important tool that OHA has to affect quality of care for CCO members. It's one of our biggest levers. So I think while it's not as potentially urgent or doesn't have the magnitude of urgency of what we've been talking about so far, I still think it's pretty important, and I'm glad to have the opportunity to talk with you about it. So I do want to talk, next slide, please, Michelle. Oh, no, stay where you are, sorry. Before I review recent events and decisions that have been made, I'd like to cover some quick basics of the CCO Quality Incentive Program. It's been in effect since 2013, and in the years since then, CCOs have in aggregate received between $47 million and $188 million per year. So not per CCO, but per year, that's the aggregate amount that they've been eligible to earn. Many of the design elements of this program are under the control of the Metrics and Scoring Committee, including which metrics are chosen, how the challenge pool can be earned, what the benchmark, baseline, and improvement targets are. And finally, I want to remind you, or perhaps tell you for the first time, that CCOs aren't required to achieve all metrics to earn all of their incentive payment. To receive the full incentive payment, they must achieve one or more of the metrics that have been designated as a must pass, and those change each year. That's decided on by the Metrics and Scoring Committee, and 75% of the metrics. So just wanted to level set there. So when I last met with you guys, we were eagerly anticipating the meeting on the 17th of July of the Metrics and Scoring Committee. during that meeting, which Dr. Santa has kindly agreed to talk about in a little bit more detail after I've finished speaking. He's going to share his perspective. Several really important decisions were made. So with respect to 2020, the committee decided that the Quality Incentive Program will be reporting only. And that means that CCOs will need to participate in the reporting of the metrics, but not achieve benchmarks or targets. The committee also decided that for 2021, all 13 of the metrics that were in effect for 2020 will be carried forward, and the health equity metric was added. So that brings the total for 2021 to 14 metrics. There are still some really big decisions, design decisions that, sorry, I should have told you to advance the slide, Michelle. Sorry. There's still some really big design decisions that remain for the September meeting of Metrics and Scoring Committee, including what reference year should be used as a 2021 baseline, the benchmarks and targets, which metrics will be must pass, and which metrics will be in the challenge pool. So I'm going to talk a little bit more about those. Next slide, please, Michelle. OHA's recommendations for the remaining decisions are based on a number of really important principles, primarily that health equity and the needs of OHP members should be the foremost considerations. In addition, OHA anticipates that all partners in the healthcare ecosystem will work together, collaborate to achieve health equity and ensure high quality healthcare going forward. So OHA has promulgated recommendations for establishing benchmarks and improvement targets for 2021 that maintain the forward momentum of the Quality Incentive Program and reinforce a continued expectation of high quality care for members. Next slide, please. All right. So OHA's first recommendation relates to baselines. And I'm going to spend probably the majority of my time on this slide because I think this is detailed and a little bit wonky, and I'd like to make sure you all understand it. So baselines are the starting points from which individual CCO improvement is measured. OHA is recommending that that 2019 be used for CCO baselines to calculate 2021 improvement targets. And our reason for that recommendation is threefold, essentially. First of all, this is internally consistent with the 2020 recommendations. So we've heard repeatedly that CCOs can't, that we can't use 2020 to measure quality because things have fallen off the cliff, and that is absolutely true. Because 2020 can't be used to meaningfully assess quality improvement, and it was made reporting only, it similarly really shouldn't be used as the baseline year for 2021, because that would be starting from a much lower baseline. Each of the CCOs would have a much lower baseline for the vast majority of the metrics. And we've done some analysis on the metrics so far for 2020 and see that that would be true. We also are considering in our recommendation that how improvement targets are set has the potential to either bolster or suppress improvement for years and years to come. So again, going back to 2020, if we were to decide that that were the baseline year, that would really suppress improvement for years to come. If we use 2019 as the baseline year, that would help hold steady and maintain forward progress. And we've made an attempt, which I will show you in the next couple slides, but don't change yet, Michelle. We've made an attempt to actually show you what that looks like. And I'll be curious to see if that helps at all. The other thing that's nice about using 2019 as the baseline is it means that everyone will know the targets right now. And so one thing that's a little bit complicated about the CCO quality improvement program is that CCOs do not typically, in any other year, when we've used the past year as the baseline year for setting improvement targets, CCOs actually don't know their targets until July of the measurement year. And if we use 2019 rather than 2020, for instance, that means that CCOs would know their targets very quickly, so at the beginning of the year. So that covers using 2019 as a baseline for the 2021 targets. The next recommendation that OHA has relates to benchmarks. And these are the aspirational goals that are set out for CCOs to achieve. So if you think about the baselines as the starting point, the benchmarks are the North Star, or where they're trying to drive to. And all CCOs have the same benchmarks. They all have different starting points. So if that helps to describe it a little bit better. In other words, well, I've already said that part. So the improvement targets are the incremental improvements towards the benchmarks, which enable CCOs to earn quality incentive payments. So OHA recommends rolling forward the benchmarks from 2020 into 2021. So rationale for this includes that it provides stability and expectations for clinics and CCOs, and it balances recognition of the current impact of the pandemic with the need to set strong and ambitious vision to continue to improve care and health for the members of OHP. So those are the decisions that will be discussed at this upcoming metrics and scoring committee meeting in September, although there's quite a bit of work that's happening in between now and then with the committee. So next slide, please. So these two slides are our attempt, and you can let me know if they work at all, to depict the upcoming decisions facing the metrics and scoring committee. So this slide depicts what it might look like, for instance, if 2020 were used as a baseline rather than 2019 for the metrics. And it depicts a situation in which quality improvement falls through the crack and in the stairs and remains suppressed for many years. And then if you look at the next slide, this illustrates how we are trying to keep health equity and care for members central to our recommendations. And that it's best for members to continue to put pressure on the system to improve care, but doing so in a way that supports the system. And so the building blocks that you see, although honestly, they look a little bit like Legos to me, we are acknowledging that there is a need to support the system, and that's what we've done with making 2020 be reporting only, which is a decision made at the last meeting that John will discuss shortly. And then we know this, because we know the system needs time to recover, and that will enable us to continue to push on improvement and innovation in years to come, and enable us to continue that forward momentum and not allow us to backslide or fall through the cracks. So that's what we're faced with right now. Those are the big decisions that the Metrics and Scoring Committee is faced with at the next meeting. But now that I've brought you up to speed of where they're going in the future, I want to turn it back to John, or over to John, to have the floor to talk about the decisions that were made at this last meeting in July, which was what the last time I was together with you, we were discussing. And then we'll have some time for conversation after that.
Thank you,
I'll
Steve.
be quick. This was the most interesting 3 hours I've ever spent listening to a meeting. Many of the themes we talked about earlier today were there big time. New normal versus old normal, fear of the new normal, fear of the old normal. lots of concerns about stability. The chair of the committee wondered if primary care practices were viable. Incredible input. It was only because of both live and submitted testimony that I think the interpreter measure passed. There was still a lot of skepticism from various outside groups about that measure, but it passed. And thank you to the folks who got that testimony together. But there was also very powerful testimony opposed to the obesity measure, and it failed. So once again, recall the decisions we made about going to innovative measures and spending time and resources on developing those measures. And after 1 to 2 years of work, the measure failed. And now we need to decide what to do about it. So, I think I agree with the decisions that Stacy has outlined. It will, I think, be greeted with some concerns and some pushback, but it makes sense to me to do what we can to push forward with expectations that we've had in the past, but be sensitive if instability continues and we can't get to a new normal to flex as the state has done so well so far in this process. That's my 2 cents.
Great. Thank you, John. So let's open up for a discussion amongst the board.
Dr. Bangberg, thanks Stacy and John for report back on what's happening in metrics and scoring. I don't know that we really have time to process it as, if that was really the most meaty 3 hours of meeting you've ever had, John. I suspect we could use more than 4 minutes to talk about it. But I'm both like struck by the logic of the decision and also the ways in which this tying specific metrics to resources in this way is a challenge. And I thought in my head about whether there's opportunity in the future to think about kind of a 2-year rolling look at things. I mean, I'm struck by the idea that in effect we're saying not only that this year's measurement shouldn't be used, but that we're kind of giving the year off in terms of the kind of progress we're trying to make over time. I understand all the challenges there. I'm not sure that they play out the same across all 13 measures. So there's a lot underneath it that I would just call out feels, I suspect we have folks I know we have people on the metrics and scoring committee who think about data and the implications of data quite a bit more than I do. But I still have both some concern and some understanding for the situation that we're in at this point. And I'll just leave it at that.
Thank you, Z. Other comments?
I really appreciate the work, the years of work that has gone into it, and though I'm disappointed that the obesity measure didn't pass, I am thrilled that Oregon has an equity measure and look forward to us continuing to forge a path and stake new ground in that area. So I just want to appreciate the effort that went into that. And John, I think your comment that testimony was really valuable in that process is important feedback, not just when we think about metrics and scoring, but for all the decisions that we're doing and how we make sure that we're being accessible and open and encouraging those voices in the process. So, thanks for the work.
Any other comments?
Chair Bangsberg, if I could just quickly, I just wanted to acknowledge the long hard work of the Health Equity Committee, the work that Stacy Schubert and her team have put in, and most especially the perseverance and focus over a long period of time by Leanne Johnson and staff at OEI to get this done. This has been a very, very hard, very frustrating path for them all, and I really appreciate their dedication to getting this across the line.
Thank you, Pat, and thank you for the opportunity to OHA to revisit this. I think this is, I have a much better understanding, much more comfortable with it after this discussion than after our last meeting. So I appreciate the opportunity to think about this and digest it a second time. So let's move on to public testimony. I understand, Steph, we have 3 people lined up for public testimony. Is that correct? Starting.
Yes, so we can start with Bruce Thompson, if you're able to come off mute, and then we'll go to Suzanne Cross and then Sandra Hernandez.
Okay, well, howdy, I'm Bruce Thompson. Nice to see many familiar faces here. I'm a family, just for information, I'm a family physician retired from a small private clinic in Corvallis. I have served as Benton County Health Officer for the past 20+ years, and I am definitely not retired from that duty, thanks to COVID. So thank you for this opportunity to say a few words about the written testimony that has been submitted by the Oregon Academy of Family Physicians. The OAFP written testimony discusses more widely collaborations between local CBOs and PCP clinics, such as exemplified by the testimony of Serena Cruz and Olivia Quaraz. Apologies if I mispronounced that. The OFP testimony pertains to much of what people have discussed today, including the impact of COVID on Black, Indigenous, and people of color, among other ongoing problems with our current fee-for-service system. We can do better, I agree. Our current financing system has not been resilient enough to weather a steep drop in physical visits and provide stable employment for primary care frontline workers. As has been shown, this is a national problem, with upwards of 50% of PCP clinics around the country having gone bankrupt. Oregon PCP clinics are struggling financially. In fact, and I'll echo some of John's concerns, Dr. Santa's concerns here. The clinic that has been my medical home for 20 years ceased to exist in April. So now at the tender young age of 71 and being a Medicare patient, I need to find a personal physician who will align with my needs as a patient, and our current system will be an obstacle to that. Systemic failures are the focus of the governor's appointed task force on universal health care, which has begun to define ways forward for equitable, affordable, universal health care for all Oregonians. COVID has underscored and bolded the need for the work of the task force. We need to think and speak from a different perspective than from the perspectives linked with that dysfunctional system. Several PCP clinics around the state are stepping up to address this wildfire of COVID that continues to spread for the foreseeable future. Virginia Garcia Clinic, Avia in Roseburg, Richmond Clinic in Portland, One Health in Hood River, Winding Waters in Enterprise, Springfield Family Medicine, All Care in Southern Oregon, to name some of the PCP clinics around the state that have developed their ways to serve their communities with public health contact tracing and wraparound services through CBOs. They are continuing to have difficulty funding those services. Not all collaborations of this type are identical, with each community needing to invent a system that best fits their community's needs. So what the OAFP is asking is that the Oregon Health Policy Board create a work group to explore the structure and sustainable funding of collaborative efforts between CBOs, PCP clinics, and public health that will fit the diverse needs of our different communities around the state. I think I stayed within my 2 minutes, so I appreciate the opportunity to speak with you, and a great discussion that you've been having all morning.
Thank you, Dr. Thompson. Next, we have Suzanne Cross.
Hi, thanks again. I just wanted to add one more thing that I had forgotten, and it's related to the CBO grants that we're super grateful that OHA pivoted again, like the rest of us are, and offered this last minute quick kind of rally of money out to the community-based organizations to partner with our public health departments and to support our healthcare providers. But I did want to just kind of address some logistical challenges around that. I'm lucky to work for a program that was already up and running, working on wraparound supports, and we're using the funding to expand our abilities to support our community. But there's a number of programs that are starting up and hiring as a result of this new CBO grant funding, and the money has yet to come in yet, and we're a month into the grant process. And then the grant's supposed to end at the end of December, and you can imagine the challenges of trying to hire contact tracers and people to run these programs and do outreach and education with this such a short time frame and not really knowing what's coming after December 2020. So I would urge this OHA to kind of try to give some more guidance around what's happening after 2020, December 2020, if at all possible, and also to help some of those newer programs who are lifting up in such a short time frame to kind of maybe extend, since the money hasn't even come in and they can't hire without that funding, to maybe extend the deadline into January or whatnot to help support these newer programs. But again, I'm super grateful to the OHA. Realize it was a total last minute pull together and something not been happened before, and we're really grateful. So thank you.
Thank you. We appreciate the real-time feedback. Next, we have Sandra Hernandez, Executive Director of the Douglas Latinas International member of the Oregon Health Alliance, Health Equity Alliance.
Yeah, doulas, Latinas, doulas. Everybody knows what is a doula, right?
Yes,
so good morning, everyone. Thank you so much for having us. It has been great that we could have much more time today from last meeting to really discuss all these issues regarding to, not just Latinx, but all the, BIPOC communities. And I just want to say thank you as well, as Suzanne Cross was mentioning, with the funds that we also are getting to work with our communities during this COVID moment. But yes, we echoed her ask about what we're going to do after December. Please help us now to plan better what we are going to do, right? And quickly, I just want to bring up a very important topic that we have not been having much time. And I hope that, maybe next meeting, whatever, but that we start thinking now. I mentioned that briefly last meeting regarding to maternal child and emotional health, which is a huge concern for our organization and our communities and partners with Black communities that we have been working as well since 2010. Yes, 10 years ago when this board was formed, Doulas Latinas International was there, myself was there to make this board happen. So we are glad that we finally have this possibility, right? To have the communities coming and talking. However, actually I would say since that moment, we could bring community health workers and doulas who support pregnant mothers, who becomes, professional workers as much as community health workers, but different roles, right? So we have that opportunity to bring those two groups of people from the community to interact and support directly, culturally and linguistically form that we didn't have before. And that has become, 50% of our mission since 2014 when we finally got all the approved process. And since then, our concern, looking to make sure we are attending mothers. So all of a sudden, 6 years, 7 years after what we have in the COVID and what happened, the first thing, all hospitals closed down the doors to doulas. And we understand lack of everything, knowledge and, PPE equipment and everything. But the point is, what's going to happen after we settle down the COVID thing? How much more trauma we are going to have with these mothers who are just having their babies now, so tense. We have mothers that we have been attending over the phone as much as we can, in postpartum, but with lots of stress and even depression. So how much increase is going to be the level of our chronic diseases after this whole process? How much can we think about this and plan to avoid? So our ask is really, please, let's work together with the hospitals and CCOs, colleagues from Southern Oregon, colleagues from Black communities. We have been working in a group already, creating a coalition to bring our voices there, and the indigenous as well, to make sure we find, a way that, mothers are not there alone, and even with the father. So what we are doing? We are trying to make the father to be better. So that's our role already. We are not concerned about that. That's our work. However, how can we have support that hospitals will be there open and CCOs supporting, and funds, of course, because to train a doula, it takes 2 years to have the level that we need. So we are doing everything we can, and we are really counting with you guys, great capacity and knowledge and support. Thank you so much for listening to us.
Thank you for that really helpful and constructive suggestion about extending doulas into community health workers and building that bridge in partnership with the CCO. I think it reinforces many of the themes we heard today. So thank you all for your public testimony, a really important part of our meeting today. I would like to thank everyone who presented today, and the people at OHA for organizing, putting it together, the staff. Thank you, staff. Thank you, Michelle, for putting this together. Jeremy and Pat for your leadership. And also thank you to all the board members. As always, learned so much from your insights and our discussion together. So we push on. We have lots of work to do, but there's a great group of people who are highly committed to doing this work and achieving health equity. So with that in mind, any last comments before we wrap up? All right. Look forward to seeing you all next month. Be safe, be well, and keep the good work going. Bye, everyone.
Bye, everyone. Thank you.